Hey there, welcome to the webinar. It's Streaming Crisis Response, Streamlining the Crisis Response, the deep dive into MCIs and large-scale events. And man, we have a great set of experts with us from across the country who will be providing you real-life case studies on how they're both preparing for and managing the unknown. We are from all over the nation. We're going to be talking about California, Nevada, Texas, Colorado. But first, just a few housekeeping notes for you before we get started. First, this presentation is both live and interactive. And when you ask questions at any time, just click that Ask a Question widget in the presentation window. Your questions will be answered at the end during our Q&A portion. And enter any technical support questions also through that Q&A, and they will be handled quickly through a member of our technical team. You might know this if you've been part of these webcasts before, but if not, they'll be available within 24 hours on demand after this event. And a reminder email will be sent out to all registrants with a link to the archive, and it'll be also archived at gems.com/webcasts. A certificate of attendance will be sent to everyone watching today, and it'll reflect your time in the session. And if you need a certificate for the on-demand viewing, please go to gems.com/certificates. Enter your information, and the on-demand certificate are mailed out each Friday. With that, there's a couple of us emceeing, and I'm going to turn this over to my co-host, Brandon Means.
Thank you, Chris. Welcome, everyone. I'm Brandon Means. I am our VP of Medical Operations here at Pulsera. And we just want to take a couple minutes to explain what Pulsera is and what we do for those of you who may not be familiar with Pulsera. So we build systems of care that scale. We're a cloud-based mobile communication platform. We believe that you should be able to use the same system every day that you would use during a surge event. And we're going to take a look at a few different types of surge events or stress events with our guest panelists today. So when we really take a dive into what Pulsera does, we like to start with the problem. What problem are we seeking to solve? And that's communication, right? So communication is difficult no matter what situation you're in, whether we're talking about a single patient or 500 patients. And so when we take a look at the problems we face with communication today, let's just take a single patient, for example. And we've got this patient that's being handed off between multiple teams and multiple organizations, and we're using many different methods of communication for a single patient. We're calling a radio report to the hospital from the field, then we're faxing or emailing an ECG. Nurse is taking a report, jotting down some notes, sending out a blast page to everyone who's making phone calls back. And so we've got this giant game of telephone. It's hard to track who said what. There's no transparency. And so we take that concept and we add value for EMS systems, for hospitals, for regions, and for states every day. But even more importantly, and we all learned this during COVID especially, is the way that we communicate on a daily basis. It has to scale for a surge event, whether that is a school bus rollover or an active shooter, some sort of evacuation for a natural disaster, or a global pandemic. And so when we look at that, the solution has to be scalable communication. And so we do that by leveraging modern technology. We put everyone that's taking care of this patient or these patients on the same patient channel. So we use smartphones, tablets, computers, and we create a shared consciousness. We offer transparency to the entire team. And so quickly, we can create a patient channel within our platform, build our team, and communicate. And you guys are going to see throughout this presentation how we do that and how we're able to leverage our technology, not only to communicate, but to track patients and to provide transparency to our teams. And so with our MedOps functionality, we take the concepts that we've been doing for many years for single patients and time-sensitive emergencies, and we apply those concepts to any type of surge event. And again, that can be a planned surge event, a sporting event, a race, or any one of the number of acute unplanned events that we've already discussed. So with that being said, I'm going to hand it back over to Chris, and then we'll go over to our panel of experts.
Yeah, we do have a great set of experts from across the country, like I said, who are providing real life case studies how they're preparing for and managing the unknown in their areas. And the first gentleman is Jeremy DeWall. He's the EMS Medical Director of Pikes Peak, Southern and Southeastern regions in Colorado, overseeing 42 EMS agencies, 6 critical access hospitals, and about a fifth of the land area in Colorado. So he puts front in frontier. The next speaker that we'll be hearing from is Eric Epley. And Eric is the executive director of STRAC, the Southwest Texas Regional Advisory Council. That system of care there oversees 22 counties, 26,000 miles. It's the 7th largest city in the US, San Antonio, with 71 EMS agencies and 63 hospitals. And we have our colleague, Troy. And Troy's in our San Bernardino, Southern California area. Troy is the EMS Fellowship Director at Arrowhead Regional Medical Center in Colton, California, and really oversees and looks at the San Bernardino County, which, fun fact, the largest county by geographic miles, 20,000 square miles for that one county. Troy is the medical director for San Bernardino County Fire Department, Mercy Air Region 2, and also what we'll be digging into, the Baker to Vegas Law Enforcement Relay Race. All right, Brandon, let's jump right into these case studies.
All right, help if I got off mute. All right, so let's just jump right in. I've already been introduced to Dr. Jeremy DeWall. So Dr. DeWall, if you want to tell us a little bit about how you guys have used the platform there in the great state of Colorado.
Certainly. Thank you, Brandon, and good morning or good afternoon, depending where you are right now. So I'm Jeremy DeWall, once again, EMS Medical Director of the Pikes Peak, Southern and Southeastern Colorado regions, regions of Colorado. And if someone could hand over the remote to me, I can continue on with the slides here. All right, excellent. So to give a little bit of history of the use of Pulsera in Colorado, and in particular in the regions that I'm affiliated with and work with, it's really been a journey. And originally we started as a group of medical directors looking at, is there better ways to communicate between our pre-hospital EMS colleagues and our hospital colleagues? And the real decision was to start with STEMI and stroke care. That was about 7 years ago in the Colorado Springs, Teller, El Paso area, as we call it. With that, we've had gradual growth of the utilization of Pulsera to the point that we actually utilize it daily for about 4,500 calls per month total in the Plains to Peaks RETAC, we call it, or the Teller El Paso area. Our first real mass casualty event, as many of you guys know, is COVID. And what we really ran into in our area, in the rural areas of Colorado, was we have a lot of very stoic people that said, you know, I don't really need to go to the hospital because everyone says, stay at home. No, the hospitals are busy. Other people are sicker. So we actually found a large group of people who were not utilizing the healthcare system, even when they were relatively sick or extremely sick, which obviously ended up causing more morbidity and mortality in our communities potentially. With that, we also had a lot of patients who were afraid to go to healthcare centers because they were worried they'd catch COVID-19 by going to the emergency department. So with that, we actually partnered with Pulsera at the time, reached out to him and said, we need a telehealth platform that we can get board certified emergency medicine docs into the home with our first responders, whether it be fire department, volunteer first responders, or our transport agencies, and be able to at least try to provide care to these patients, discuss with them whether or not we think they need to go to the ER for further care, or be able to get prescriptions and other components to them in their community by utilizing telehealth. This started in 2020, obviously, with the COVID-19 pandemic, and was hugely successful in managing our almost 2-year mass casualty event that we were dealing with in our rural communities with extremely limited resources. From that, we've really expanded. So if you take a look in the upper left corner, that is the city of Colorado Springs to the west, the kind of lighter pink area. That's the area that the original telehealth actually started occurring and utilizing it for the COVID-19 pandemic response. Subsequently, there's been expansion. The city of Colorado Springs has been using it under other medical directors. Our Eastern Plains out to Cheyenne Wells does. And then the areas that are currently expanding are the areas, as you can see down by the Crestones, which is a large valley in the middle of two mountains, down into the lowest reaches of Colorado by the Trinidad, Aguilar, Branson area, and all the way to our farthest reaches of southeastern Colorado, which have their own unique technology and communication issues, being much like the Great Plains of the United States, where there's vast areas, very limited technology coverage, very limited EMS coverage, and numerous critical access hospitals that are really giving it their all to care for their community. Now, when we think about in our areas, the rural areas of Colorado in particular, we have massive, vast areas of land, whether it's the Eastern Plains or it's areas like this in Teller County, and just areas that there's not a lot of people, lots of trees, lots of topography, and one critical access hospital to serve the entire area. So for us, our EMS response, a mass casualty event for us may be 2 or 3 people. It depends on the volume. We have typically in our Teller area, for example, 2 to 4 ambulances on at one time throughout the entire county. So event like this, which is one of our local fires of a home, with having 3 or 4 patients potentially involved in this, along with tying up our first response, which are usually volunteer EMS providers, that's a mass casualty event. Nobody really in this situation has time to contact all of our local hospitals and say, hey, who can take these patients, who can deal with this or manage it, even in smaller scale events. So utilizing Pulsera and the mass casualty function really allows us to alert hospitals quickly. Now, the same community actually has larger community facilities that house up to 3,000 to 5,000 people in one weekend. So the potential for very large scale disasters can occur as well. And obviously that further strains our system and requires us to have a very quick, easy, efficient process to track patients, to notify hospitals, to have all those components. What we have started is utilizing in the area, very similar to Texas, who actually originally came up with this wristband, and we kind of borrowed it from them, changed the word Texas to Colorado and went with it. And it's been hugely successful. So this is a very simple wristband. For us, they're about 10 cents a piece is what we pay for them. We did add some wording, do not remove until patient discharge. And the thought process with this is every patient every day gets a wristband. So if you do it every patient every day in a mass casualty or disaster event, you're used to doing it. It takes a second to stick on there, take a scan, snap a picture of their face. And then when we find an ID at some point, we scan that in so we have that information, and it allows everyone from first response all the way through to our hospitals, to our transport agencies, once we know who that patient is, to be able to have them properly identified for tracking, for your EPCR completion, for your billing, for reunification, for all those components. So thank you to Texas for coming up with this and letting us kind of sneak it from them. We've since moved into what's the future for this. There's really a lot. We've had the Club Q shooting in Colorado Springs, which quite frankly, we didn't have a very efficient way to communicate to the hospitals very quickly. There was a mass casualty event. So with that, we now use Pulsera in that area and are rolling it out through our other areas, that it's one button, notifies all of the hospitals, also allows other EMS agencies to tag on to that so that we have that, know who's actually responding to, especially in our rural areas. We're planning on utilizing also for wildland fire evacuations. Like this is the 2012 Waldo Canyon fire that we did not have this technology. Last year we had the Boulder fires, which did result in hospital evacuations and really has put fuel on the fire for multiple areas in Colorado, solving this problem for good of how do we track patients? How do we declare MCIs? Our plans for this is to actually utilize it for patients who have multiple medical conditions or medications and end up going to a local community center, evacuation center. The plan is to use public health nurses and other colleagues to be able to wristband the patients, scan their ID, put their medical history in, take pictures or photos of their medications. And that way, ultimately, if we have a secondary EMS response, if they run out of their medications, if there's another issue, not only do we know where that patient is or that person is, but when our community paramedics show up, we can actually scan that wristband and have all of their data instantly. If the patient needs to be sent to the hospital then will have all of that information preloaded, pre-prepared, so that it's a seamless transition for that patient at that time, because they're obviously dealing with the potential loss of their home, the loss of their community, and the loss of their support structure. The thing they certainly don't need is the loss of their private health information, the loss of their transition to care that they're going to need as they move on to their future life with this. So the other component that we're really looking at along with these wildland fires is actually hazardous materials as well, a response. And one of the components that we've discussed utilizing this for in the future, which thank gosh we haven't had to use yet, but have trained in, is actually using it to assure that hospitals have direct communication back to the primary decontamination teams that are on site, whether it be fire departments, mine rescue teams, those components, which can actually streamline whether or not a patient requires secondary decon at a hospital facility prior to receiving treatment, which our goal is to ultimately speed up treatment and care of tox patients and hazardous material patients by being able to have that two-way communication right back to the person who actually completed the decontamination and knows whether or not they had a full decontamination or if there's any concerns further on. So with that, I'd like to say thank you for the time, and glad to tell you about what we're doing in Colorado.
Man, super great work, Dr. DeWall. Always good stuff. And we think about it of rural, under-resourced areas. How can we make sure that we're using the right resource at the right time with the right people? And which then says, well, what if we have a lot of resources? You have the same problem. How do we get the right resources to the right people? And with that, we're going to be moving over to Eric Epley with Texas. Eric has been a visionary for way before Pulsera even existed. And then when Pulsera came around, he's like, we have to take this not from a hospital, but not to just our community, but not to a region. How do we make this a statewide initiative? And it's been a great journey. So with that, Eric, let's do this.
Yeah, super. Thanks, Chris. As Chris said, my name's Eric Epley. I'm the Executive Director and CEO here at STRAC, which is part of the Texas Trauma System. I'm also the chair of our governor's EMS and Trauma Advisory Council's disaster committee, which is where we're running into a lot of problems. Today, I'm going to talk a lot about my core philosophy that I believe that day-to-day, well-functioning regional trauma and emergency healthcare systems are essential to good disaster response. I think sometimes we think of it as an emergency management versus EMS, and I just see that as a big continuum. You look at a hospital, an ER on Saturday night at a trauma center looks a lot like a little mini disaster most places anyway. So I think, disaster is just the trauma and EMS system cubed with some other partners. I'll talk today about El Paso, our experience with Pulsera in San Antonio, and then our addition with the wristband, what we're doing today and what we're doing, in the future. So everybody from Texas, there's no way I'm not going to do some kind of Texas is a big place slide, but it does put it to scale. This is about 30 million people in Texas, and there's just a lot of miles. And in some ways, it's harder to get everybody on the same sheet of music because the things are so different in different parts of the state. It's been a big challenge for us. My area is in San Antonio, which is that area P, Trauma Service Area P. The state's divided up into 22 regional advisory councils. And we have about 26,000 square miles, seventh largest city, and 71 agencies, and 63 hospitals. Of those, we also have 18 air medical bases, 2 level 1 trauma centers, 16 PCIs, 17 stroke centers. 3 of those are comprehensive. And we have a big crisis behavioral health effort here as well. So I'm going to talk first, Pulsera we had looked at with some other products about 6 years ago, and we didn't do it at the time because it just wasn't the right time. When COVID hit, everybody was given, EMS reports that sounded, we used to have face respirators. And so it sounded a lot like the 37-year-old male with third effect. And so the nurses were complaining about the patient reports, and we thought, hey, Pulsera seemed like a pretty good idea. I think it would be essential now. So we transitioned over to that and started using it on just regular day-to-day EMS stuff. Well, when COVID hit in a big way. One of the waves. El Paso, Texas, is about 1 million people during the day, and San Antonio proper is about 2 million people. We have 24 hospitals in the city proper. El Paso, you would think if they're half our size population, they would have 12 hospitals. In reality, they have 7. And so they're actually, there were times they were running physically out of beds. We would have problems with surge, but they were staff problems. We had beds. We could open up another wing. We just didn't have nurses to do that. El Paso literally ran out of beds. And so we were having to move patients. We moved about 250 patients in a little under a month. And so El Paso, I call it moon base El Paso. It's pretty far away from anything. So every movement required a jet, an air medical provider to do those moves. And so the border rack, which is my peer, hospitals on the left would call into border rack, say, we need to move a patient. They would call our state coordination office, the coordination center. We would look at the other regional advisory councils and say, hey, can anybody take this patient? All this was all doing phone calls and literally would be, 35, 40, 50 calls just to get one patient accepted. And we thought, wow, the transfer feature that a lot of EMS people don't really know about, but there's a transfer feature of Pulsera that hospitals can utilize. And it streamlined all of this for us and made it much, much simpler. And, the hospitals now are entering the patient into Pulsera, and then they would go to their regional medical operations center, their RMOC, and then that would be passed. Same flow, but with Pulsera, it just made it so much easier. All of the transfer paperwork is there, any pictures or EKGs, anything, and then for the first time ever, both the sending and we'd had the flight crews in on the jet when they took off. And we had several receiving hospitals say, good Lord, this is the first time ever we've known, like, hey, the jet just landed. They're on the way over to pick up the patient. They're leaving to go back to the airport. Okay, they're lifting off. It's like we've never had this kind of visibility before, and it made things so much simpler and easier. This was a big win for us. The deployment across the state's going pretty well. 354 EMS agencies, 423 hospitals. I think we have a little over 600, so we're not there completely yet, but we're moving fast to try to get that done. We had 48 hospital signups and 29 EMS signups just in like a month's period. Recently, it was one of the meetings we did, but you can see the expanse. It's about 40,000 Pulseras a month in the state, and my region STRAC is about 11,000 of those 40,000 Pulseras. Another thing, so in disasters, I've dealt with the hurricane tracking problem, patient tracking problem, and we've had wristbands, but the wristbands we had were provided by the emergency management guys, and we never really had them in the right place at the right time. And I thought, the only way this is ever really going to work is if the band is in the ambulance, like a box of gloves and a box of bands. And further, I've been a paramedic over 30 years, flown 15 of those. I've been to a bunch of MCIs in the helicopter. I've never seen a single triage tag used. I mean, really ever have seen a triage tag used. But we talk about them all the time. It's just not used because when people get in the worst day of their life as a medic, they're going to do what they know to do. You put a blood pressure cuff on every patient. So amazingly, in a disaster, you put a blood pressure cuff on them. So in that theory, the muscle memory of if you put a wristband on somebody every single day, it just becomes part of what you do. Then on disaster day, you're going to do that. Combine that with Pulsera and the ability to scan. Most of our agencies don't have enough to surge. Even San Antonio Fire doesn't have 40, 45 trucks on every day. They don't have enough trucks at an airport, crash, a plane crash. Other agencies are going to come in. And one of the huge values of the wristband now is once that wristband is on and maybe you made them a red or a yellow and you gave them some initial treatment, but a transport unit pulls up from another agency. If they're in Pulsera, they just walk up, scan that wristband, and they're instantly added to that patient's communication line. So the wristband, same thing when they get to the hospital. They show up, they scan the wristband at the hospital, and they're instantly added into that patient, and they can see all the information that's happened since the very first entry, and that's been fantastic. I like to say the wristband at Pulsera is a little bit like, hey, you put chocolate in my peanut butter. It's like, no, you put peanut butter in my chocolate. So the two are synergistic and have been, super helpful for us. I'm terribly embarrassed that this is going to take off the color. It was the worst color ever, but I will tell you, that color is not in any of the other hospital safety, fall protection, any of the other stuff. So we deconflicted, and I said, well, I know why this isn't on any other band, because that's the worst color ever. So no wonder no one picked that color for one of their safety features. We're using the top one across the state. We bought several 100,000 of them with some legislative dollars a couple of years ago, and every rack distributes those. The one below, I have to give shout out to North Central Texas rack, the neck track in Dallas. They designed this in their EMS committee. It's about 4 times as expensive. And so, some regions are deciding to get those and maybe keep them on their ambulance, like 25 of them for like we used to keep triage tags. But really, the one on top, just like Colorado, we're using that one every day. It's simple. It's 8 to 10 cents, and it's worked out really well for us so far. New technology, old problem. Just like I said, muscle memory is key, and if they do it every single day, they're going to do it on disaster day. If you notice the screen on the bottom, the summary sheet now, the ability to see what patients are on scene, en route, and at destination. I've always felt like unless medics are using a technology tool every single day, we should never introduce new technology on game day. It's not going to get used. It's the updates won't be in the software, whatever. So unless they're using the software every single day, and that goes the same for the wristband. If they're not using the wristband every single day, that's how those things marry up. The newest feature they've added, and I got to give a shout out to Pulsera. They have not slipped on any timelines so far. And they continue to pump out new features kind of constantly. The newest is now you can scan, the ER can add a POV or a walk-in patient. And so if you're an incident commander, you're going, man, we've transported about 25 here, but they scattered like mice when we first, when people were running out of the theater or whatever. And you don't know who got to the hospital by, donkey or a pickup truck. And that's a real problem as an incident commander trying to manage, because we're managing the incident. We're not managing the EMS patients transported. We're supposed to be managing, how big is big and how bad is bad. And so this tool with the hospital is able to put a wristband and scan the patient into Pulsera. It gives you a total number and a complete common operating picture. Our Texas Emergency Medical Task Force program, STRAC is the lead agency for that with the State Coordination Office. We have 8 regions in Texas that are multi-rack regions, and this is how we respond to the big disasters, like when the West Texas fertilizer plant blew up, hurricanes, tornadoes, etc. These 8 multi-rack regions are across the state. I know the numbers don't match up. We match them to our public health regions, and they can't count. So we're just trying to stay in line with their numbering, but it's really frustrating. People go, why are there 11 and it's 8 regions? But just it's public health. So this is the design of the entire thing. So every region has this makeup. So you have task force leadership with task force leaders, group soups, etc. Medical incident support teams are basically LNOs. The ambulance staging management teams, we type those from type 4 to type 1, with type 1 over 250 ambulances. Ambulance strike teams obviously is, about strike teams. And we have about 20 ambuses, 8 of these field hospitals. These are 16 to 32 bed hospitals with emergency medicine doctors, PAs, nurse practitioners, nurses, etc. Nurse strike teams. And then in the last 5 years, we've signed every air medical program in the state onto the air medical strike team concept. And that's been super valuable, because once we activate that, they're paid a stipend, like a flight time stipend or a standby stipend, and we cover all their salaries. So that aircraft is essentially ours to use for resupply or to move, communications equipment or personnel. And that's been really helpful during hurricanes. The infectious disease response unit came about after the Ebola crisis, and it was helpful in COVID. And then we have a Timor, Texas mass fatality team, and then tactical medics and wildland fire support, which this year has been pretty crazy. They've been deployed 78 days with about 8 packages across the state. That is it.
All
That's
right.
my cue up slide.
Well, thank you, Eric. Yeah, great stuff representing Texas well. I personally like the color of the wristbands. It reminds me of my grandmother's jewelry. So, yeah, to each their own, I guess. But thanks for that summary. And we're going to go over to Dr. Troy Pennington now in California and talk about a different type of surge event or stress event, and that's a planned mass gathering, whether that's a sporting event or a race, and finding unique ways to use a scalable communication platform to not only communicate with your crews, but to track patients. So, Dr. Pennington, over to you.
Great. Thank you so much, Brandon. And it is truly an honor to be here with everyone from GEMS and the Pulsera team. Let me see if I've got control yet. It hasn't come over to me yet, Brandon.
I don't have control either, so good luck. I think we'll get it to you shortly.
All right, hang on. I just got a notification. It's coming here in just a second. I'm still waiting.
It says it's waiting on you to control the screen.
I got nothing on my end.
Maybe try to click. There you go.
There it goes. All right, great. Thank you so much. I'm going to click in here. Well, again, thank you, everybody. And it's truly an honor to be here. Again, my name is Troy Pennington. I'm a recovering firefighter, paramedic. I started my career in the early 1980s. I'm coming up on 40 years in EMS. I also hail from Texas. I'm going to give you another kind of view of that. One of the things that we're doing is we're running this very large event called Baker to Vegas. I work in a couple of different roles. I'm currently the EMS Fellowship Director at a place called Arrowhead Regional Medical Center, which is the San Bernardino County Hospital. And again, San Bernardino County is this huge county of over 20,000 miles. I get to work with the county fire department and one of our aeromedical providers in the region. But one of the unique opportunities I've had is I've been able to serve as the medical director for this crazy thing called Baker to Vegas, which is this law enforcement relay race that's spread out over 120 miles. So each year in March, I'm overseeing this mass casualty incident of about 7,000 runners. And when you add in all the participants, the teammates, the spectators, we literally have a city moving through Death Valley, transitioning to Vegas. And so how do you have situational awareness on such a big event? Now, this event with the 7,000 runners requires a huge medical team. Our medical team is made up of almost 200 personnel. And what we do is we stage them at 20 different first aid stations throughout the race. This race started in the late 1970s by two gentlemen. There was a gentleman named Chuck Foote and Larry Moore, the former Larry Moore. And it used to be called the Death Valley Race. And, the way I saw this, and I talked to Chuck once upon a time, it was a bunch of officers and they were kind of talking smack in a bar. And they're like, oh, yeah, well, we'll race you 100 miles. No, we'll race 120 miles through the desert. And then they said, well, we'll do it through Death Valley. And that Death Valley race transformed in 1985 to this thing called Baker to Vegas. And what's been interesting about this is it's designed to, encourage physical fitness and camaraderie in the law enforcement community. And racers come from all over the world, as far as Australia, to compete. And it's not for cash or prizes, it's pride for the badge and trying to serve fellow man. And so it's been a great honor of mine to participate in this race. It starts from that big thermometer just north of that in Baker, California. And our racers are running here. This is Death Valley Road. This is Highway 127. And so this is your office for the race. So there's fewer, more austere environments. And so our medical team is setting up about every 6 to 10 miles along this long course, and they're attempting to provide medical care. And one of our huge challenges is that in some stages of this event, we're more than 80 miles from the nearest hospital. And so you literally have the supplies that you've got at the side there. And then, we're trying to transport people out. On the California side of the event, generally we're running somewhere around 12 ambulances and 3 helicopters. And then we have a similar contingent on the Nevada side. Now, it finishes in Vegas. The finish line this year is going to be at the Rio Hotel. And the runners, again, each runner is running not the whole distance. They're running a leg of the race. They're running about 6 to 10 miles. And this was one of my favorite pictures from the past few years. This is a police officer from the San Diego Police Department. Imagine it's difficult to run this race enough if you're running a t-shirt and shorts. This was in honor of a fallen officer, and they were running in their full kit. They were wearing their tactical vest, their belt, their khakis, and their boots, carrying this flag and the baton in the other hand, and then passing that off every 6 to 12 miles throughout the event. Now, the stages are on the side of the road, and this is an active freeway. So the freeway is not closed down during the event. So you've got all the traffic of the event, plus all of the other traffic that's running on this freeway. And you're trying to push all of that information back to a command post. When I started with the event in 2017, we were on paper. We were essentially putting information on the back of the runner's bib and using good old-fashioned triage tags if we had a big event. And what's happened is we've transitioned to, we've gone from what I consider the 8-track tape of technology to the digital age. Now, our medical teams are made up of all volunteers. There are nurses, paramedics, doctors, PAs, firefighters. Everybody is volunteering their time to provide medical care. And these little first aid stages, again, are set up about every 6 to 10 miles. But the thing that's been difficult for me as the medical director is having that situational awareness, trying to know how many active patients I have at different stages of the race at any given moment, how many of those patients are en route to the hospital. How do we essentially account for it, and how do we, shift all of our resource and put them in the appropriate area? And we've really never had that visibility before. So we've been in the process in the last 2 years of this transition from paper to Pulsera. On the runners, they're all wearing this thing that's basically a runner bib. On the runner bib, it identifies the team that they're running on, and then we can see the stage that they're running. And then on the back of that bib, it provides their medical information. And so that's if they took the time to fill it out. But if you have a collapsed person in the middle of Death Valley, you start to do your assessment, you pull up the bib and you look and you find that there's absolutely nothing there. What could we do better to improve that communication, to be able to provide that situational awareness? So what we're working on now is we're working with the Pulsera team on creating a runner database so that we have the medical information of all of the runners ahead of the event. We've essentially created that patient channel before everything starts so that when we scan that wristband, we immediately have some background information on that runner. And then we can add to that as we create that communication line. So this is, oops, let me back up one here. This is an example of some of our early workflow that happened, a couple of years ago. I was able to sit down with the Pulsera team. We spent some time in my home office, and we were communicating on how we're going to organize this stuff and put it all together in one package. We partnered with Verizon, and Verizon has donated to the event a series of tablets and phones so that it allows us to communicate with everybody throughout the course of the event. One of the testaments to Pulsera is the simplicity and the ease of use of the app. Believe it or not, it's nice. And, as Eric mentioned, he believes the best way to do this is, for something that they're using to create muscle memory every single day. One of the huge challenges that we have with our particular race is that our medical team only meets one time the day before the race. And so we have to be able to get them up to speed quickly. Brandon and Kate from Pulsera were able to, in less than an hour, train all of our medical providers on how to use the app and how to create an incident and to manage patients in a very brief period of time. And we were able to get up and running on the event very, very quickly. And literally the following day, we are able to transition that into a live event. At every single stage, they had Pulsera. At our command post, which is out in the middle of the desert, we had Pulsera. And we were able to see exactly what was going on at every single stage, giving us that visibility that we've always wanted. We have the ability to see what's happening. We have medical dispatch from medical. We have the ability to do medical dispatch. But now what we've added is that situational awareness that I've always been looking for. We have the ability to have a big tracker board. And so at any given moment, I can see how many patients I have along the course of the race. I can see how many greens, how many yellows, how many reds, who's en route to the hospital, who's arrived at the hospital. I can drill down to specific patient information. I can see their EKG or a photograph. So it's provided us a new level of visibility on the race that we've never had before. This other unique piece has been the wristband. It's really been a game changer for us. So if we're able to create that database of participants before the event, what we're able to do now and what we hope to be able to do in this year's event is when that runner hits the finish line, we assess them. We're providing a medical screening. At the same time, we're quickly scanning that wristband, and then we're putting them into a triage category. So we have this runner from LAPD. They've just crossed the finish line. Hey, how you doing? Great race. How you feeling? You having any other symptoms? Where you guys going tonight? We're trying to medically assess them, but it has to happen fast. And at the same time, we scan that wristband. If we've created that database of runners beforehand, we have their medical information. We scan them. Everything looks great. We hit the green triage tag. They're on their way. They're off to Vegas. If we have a runner that's having problems, they're having some nausea, some cramping, some other issues, we tag them. Let's say this person's a yellow. We tag them. Now they're a yellow. And so now at the command post at med base, I have that oversight. I can see how many yellows, how many reds I have along the course of the race. And again, we've got this new visibility that we've never had in the past. So, shameless plug for Baker to Vegas. It's an all volunteer event, bakertovegas.net. So for those of you that would like to see this in real time, we'd love to have you out, and you can see how Pulsar works on a big mass casualty incident. It's been an absolute honor to be here with you all today, and I'm looking forward to your questions in Q&A. That's all I've got. Turn it back over.
I love it. There's so much good stuff there, Troy. And the questions are coming in, and they're coming in. And Brandon and I offline were saying, wow, everybody is super engaged on this. This is great. And I love it. So we're going to be walking into the Q&A section right now with the roundtable discussion. And I'm just going to kick this out to start out with the group. So this is to the three presenters. A question was asked that is a great question. Since we didn't do any demos, we didn't want to get into the details. We want to talk about case studies and how we make a difference. But when somebody walks up to you, you're in the elevator or whatever, and they're like, what is Pulsara? What do you guys say? What is Pulsara?
I usually say it's a communications tool that we use to communicate with EMS and hospitals. And it also has the ability to help with interfacility transfers after the initial transport. It puts everybody on a common operating picture. I have said, if you have GroupMe or another app like that, this is like GroupMe for patients that's HIPAA secure and has some other features as well. I will tell you there's not Siri, but whatever it is, their dictation is fabulous. It's not Siri. That's what I will say, because Siri helps me a lot, and not always in a nice way. Their dictation, I've tried to make it like atrial fibrillation. I just try to make it go wrong, and it's very accurate, which helps when you're dictating the patient report.
One of the things I'll say is it's the dirty secret of every emergency department. For years, we're put in a situation, especially for me as an emergency room physician, that, we did not have a HIPAA compliant way to communicate. And, I look at that truly as that shared consciousness. As an emergency physician, they want us to accomplish all these things in the emergency department. They want us to get consultants in. And in the middle of the night, we didn't have that communication tool where they're like, hey, send me a picture of that break. Do I need to do surgery? Do I not need to do surgery? They would really struggle with that. And, we were told that we couldn't do these things, but we weren't given a solution to do that in the emergency department. So this has really opened up a new line of communication for us to do stuff in an encrypted, HIPAA compliant manner. Again, everybody's on the same page at the same time. It's truly a game changer.
Yeah, I would add to that when I try to explain it to people, it's really, the bimodal communication, but it actually improves patient lives and patient care. So from the day-to-day patient that you can, in a rural critical access hospital, have a local stroke program like we do with EMS, that a stroke patient walks in, as soon as we realize it's a thrombolytic potential patient, EMS is part of the team and is already heading over to the hospital to be able to transport that patient with thrombolytics, or if they get TNKs, it's done already, but immediately to a comprehensive stroke center in a more urban area. Those type of situations, to the mass casualty events where we can track patients, we can reunify families, to the critical access hospitals that, as simple as a motor vehicle collision, and their radiology tech and lab tech are at home, that when that trauma alert comes in based on our predefined criteria, that those folks at home say, oh, there's a trauma patient coming that I need to get to the hospital, and they end up meeting the patient at the hospital rather than getting there 20 to 30 minutes later for evaluation and care of that patient. So it's really a streamlined approach to patient care from the pre-hospital to hospital setting, developing those systems of care that ultimately improve patient outcomes day to day and in mass casualty events.
I say, let's see, I say a couple of things. I always say, really all we did was fix the facts and walkie-talkie and handheld radios and pagers and answering service problem, right? It's, and back in the day, we would say, why would you text me and type in all those letters when you could just call me? And in today's world, we said, why'd you call me when you could have just texted me that information? And so really, we're a HIPAA compliant WhatsApp. And with that, Brand, I know you had another question here for Eric.
Yeah, so I think Eric might be the best one to answer this one, but anyone else, feel free to chime in. We had a question that said, what type of resistance do you get from evacuation centers, and how do you overcome that?
We haven't really had any resistance from the evacuating hospitals. Now have wristbands. A lot of the ones that know they're going to have to go, there's some in Corpus, for instance, that's kind of near us. It's about 2.5 hours away. And they're going to pre-band and pre-scan and pre-enter all the patients. So when we get there with 25 trucks and an ambulance, we're going to clear out a 45 bed hospital. We just walk up and the medics scan it, and they've got everything they need out of essentially it's not the medical record, but they grab the paperwork, they get scan, and now they're in that channel and have everything to do. And then when they add the receiving hospital, which we usually do once they're on the way, we coordinate that through our regional medical operations centers and tell them, because when they're leaving, they may not know where they're going, which seems a little odd. But if you have to move 2,000 patients in about 36 hours, there are some things the MOT may not have a destination except Armonk, San Antonio. And we'll fill that in later as we figure out where those patients are going. We're going to accept it in San Antonio. We just don't know where. But we usually do that stuff while they've got, evacuations are tough because you're moving hundreds of miles, and so is everybody else. The general population's moving. So it's slower, and we have time to make some of those decisions and stuff. So there was also another question I was going to deal with the wristband. The NASIMSO, the National Association of EMS Officers, our state director brought that if everybody would we're using 6 characters, but they're alphanumeric characters for our numbers. So it can be, that gives you, we took out S and I and O. So it's the alphabet minus S, I, and O, because they look like 5, 1, and 0. So if you see a 0, it's a 0, not an O, etc. And then that gives you kind of a base 33 number, right? You're not just you're not 0 through 9 anymore. You're actually adding a lot more opportunities, which makes the number itself shorter, like a license plate. So we can have alphanumeric characters for 6 slots. And then if you put a TX in front of it, that wristband number is literally, a unique number. So that's pretty cool. And the NASIMSO people adopted that if they did wristbands, they would put their 2-digit, state identifier at the front of their number.
Great. Yeah. Thanks, Eric, for that information. There's a couple more questions specifically about the wristband. So I think let's go ahead and address those while we're on the topic, because they're not Pulsera wristbands. We can scan anything with the barcode or a QR code or a PDF 417. So, including triage tags. So, just keep in mind, the wristbands have been a fantastic project, but this is very new. We've been tracking patients, we've been helping communicate and hand off patients for many years. The wristbands and the barcodes specifically just makes it easier, right? We kind of took a page out of the book of UPS and FedEx and these logistics companies that are really good at tracking packages, right? Because every time a patient moves, you're scanning it. It's going to say, hey, at this time, it's going to timestamp it. It's going to hand that package off. And so we kind of took a page out of that playbook and applied that to patient tracking, reunification. And so hopefully that provides a little clarity around the Pulsera wristband combo.
The scanning, Brandon, the scanning works well on the driver's license. If you flip your driver's license over, there's that funny looking, it's a two-dimensional PDF 417, I think. But Pulsera works great to scan that. And then you don't have to enter any demographics, which is pretty cool. And then several of our hospitals are putting a second iPad up front at their registration desk. So it's going off in the triage nurse or radio room or whatever, but it's also going off at registration, and they're pre-registering, and then they'll write back what room number they're going to. I mean, if they actually have a room, they'll put the room number, and you can walk in looking at your phone and know kind of what room you're going to before you even, they're registered before you even get there, which is slick.
Yeah, the driver's license scanning has been that's every day. Outside of an MCI, that's every day. I know that you love pulling up into an ambulance bay and doing CPR, and then someone pops open the doors and starts asking you what's the patient's name and date of birth. I know that's everyone's favorite thing to do, but imagine pulling up to the hospital with a sick patient and they're handing you your face sheet and stickers and wristbands and say, hey, the orders are already entered for this patient. So yeah, things like that, getting demographics in early, that's another advantage of our scanning technology. One other question around scanning, I see, it says, how are patients PHI secured using this system and wristbands, and what prevents unauthorized access via a separate scanning device? That's a great question. The PHI does not live, information really doesn't live in the wristband or the barcode. That's simply saying, I'm scanning this barcode, I'm scanning this wristband to create a patient channel. I'm going to enter the information in Pulsera, and so that's where the information lives. It's within that patient channel in Pulsera. So if I'm triaging 30 patients and I'm banding, scanning, taking a picture, ambulance shows up to transport my patients, all they have to do is scan that barcode to find that patient. So the information lives within the Pulsera platform. It can only be scanned and found using the Pulsera platform. So someone walks up with another scanner and they scan the wristband, it might grab a code, but zero patient information. So
right.
That answers that question.
Yep. And it's also, like we said, it's HIPAA compliant. Everybody's set up as a user, and everything is tracked with the break the glass, everything you would expect in any type of electronic communications around patient information. Sorry, Eric. Go ahead.
There was a question about EMR integration. So we have about 55 agencies in our regional charting product. We were with Zoll, and we're actually swapping as we speak over to ImageTrend, and the Pulsera to ImageTrend integration works seamlessly. It's like if you scan the driver's license, you're putting stuff in, it just pushes the ImageTrend with a push of a button, which has been really slick, so that you're not having to put the patient's name and stuff in the EMR. I don't know. I'll let them answer about Epic and the other stuff, but I think the more you think of Pulsera as a communications tool as opposed to a charting tool, that's better, because they're really not it's not like a mini EMR, but there is stuff like being able to scan the driver's license that makes it a little bit easier, because you're already going to have to do that to tell the hospital you're coming, and being able to push that over without having to rescan the driver's license or whatever. If that's just automatic, it's pretty slick.
Yeah. So long story. Thanks, Eric. And the question about, do you integrate with ePCRs? Great example. The way we do that, it's pretty simple. We have a public API. Any ePCR company can consume that API and pull in the Pulsera data to their ePCR just like they would from a CAD or from a cardiac monitor or any other source.
Yeah, so let's add this one to the group. A number of people have asked it in different forms, and was really about, how is Pulsera's program funded for all these agencies? Any grants or government funding? How did this work through? And I know each one of you guys have a different question on this, and I'll start with Jeremy.
Yeah, so it's kind of a mix of everything. So the Pulsera One platform, which is the basic EMS to ED communications, free for the hospitals and the EMS agencies. So a lot of our rural hospitals and EMS agencies, that's kind of their starting point, is to have the very basic communication, essentially replacing the radio or telephone call and being able to communicate day to day. And then as you add more functionality, so as you add the ability to do video telehealth or telebehavioral health, of which we have agencies who utilize a tremendous amount of telehealth throughout Colorado, utilizing Pulsera with board certified EM docs. We have multiple agencies that utilize the telehealth video platform, actually working with our behavioral health master's level clinicians throughout the state to be able to actually do telebehavioral health, especially in rural areas. We just expanded to another super rural and frontier county in Colorado that's been hugely successful with that through our Office of Behavioral Health, or which is called BHA now, Behavioral Health Administration. So those, when agencies individually are doing it, some of the agencies are paying for those additions. We do have, as some of our regions, so we have sort of like the STRACs in Texas. We have RETACs, the Regional Emergency Trauma Advisory Councils, and there's 11 of those in our state. So we do have some of them, along with some of our healthcare coalitions, which is that public health overlap one that Eric was talking about. Very similar model in Colorado. Between them, they have different funding mechanisms that are available to help fund some of these programs. The state of Colorado, through our Office of Preparedness and Response, actually started a patient tracking task force just over a year ago, which has made recommendations to the state and is looking at ultimately our goal with that patient tracking task force is to actually have statewide funding, both for the communication platform as well as for the wristband platform, that they would all be purchased at the state level and available to any agencies, hospitals, et cetera, that want to utilize those. So really, there's lots of different funding mechanisms. We get funding through behavioral health grants. We get funding through opioid grants. We get funding through rural national EMS grants. And then primary agencies paying for it. We're looking at statewide if they will pay for it, and then our regional money and grants. So it's kind of a mix of everything for us.
We funded it initially with COVID. We just made it it was a COVID expense. That's how we deployed it initially. And then as we came out of COVID, we happened to be in the middle of our legislature meets every other year. And we just happened to be in the middle of a legislative session when, we realized this was something we wanted to continue in the state, working with our state health department and some of the RACs. We pushed for funding for this kind of patient, a little bit like what Jeremy was saying. Like our GTAC disaster committee has been pushing and talking with our emergency management directors, and so this was top of mind to have a patient tracking capability for the future with the communications tools. So the legislature funded that for the entire state for all EMS and hospitals at the Pulsera One level. For the higher level capability to do stroke team notifications inside a hospital and all that stuff, the state, the government gets out of the way at that point and says, we're providing a communications tool to track patients and for you guys to talk effectively in a pandemic or day to day now, but we're not funding an HCA or a tenant hospital to be able to notify their stroke teams. They need to pay for that themselves, so they contract directly with Pulsera. And we've had 3 or 4 major systems. Their one call centers are now getting their transfer requests through the Pulsera app by the sending small rural hospital just puts it in and it goes automatically, and they assign the beds and do all that communication for an interfacility transfer. And those big health systems are paying, I don't know what they're paying, but they're contracted with Pulsera to do that essentially as an add-on.
Thank you guys for addressing the cost. I'll have one little bit on that as well. As you can see, there's a variety of ways to fund projects like this, whether that's COVID money, state money, federal money, grants. Hospitals and EMS agencies have purchased this outright with their, budgeted for it and purchased it. But one thing to note is, I know today we're focusing on the patient tracking, the MedOps functionality, but all day, every day, if you want to use Pulsera to replace your radio report to the hospital, to send ECGs, to do even live video telehealth between the field and the emergency room. If you're looking to improve the way you do that and not give the radio and phone reports, that's free. That's called Pulsera One. That is a free service. We think that we should be able to replace the radio and ECG transmission and things like that from EMS to the hospital for free. So that infrastructure can be used today at no cost. And then when you overlay the ability to scale communications with these virtual placement centers, like we talked about in Texas, or MCI tools and things like that, generally purchased at a regional or state level, that's when you really get, as Eric was talking about, the chocolate and peanut butter effect, where you have the best of both worlds. It's utilized every day, but it also doesn't break down in a surge. I know we're at the top of the hour. We're going to go for a little longer. So if you guys want to, anyone wanting to hang on, we'll stick around for a little bit because we've got a ton of questions coming in. One of them was specifically about reunification. I think that's something we don't talk about enough when we talk about MCI. And so, Jeremy, do you want to start that one off by answering, how does Pulsera work for reunification?
Sure. Thanks, Brandon. That's exactly what, honestly, our patient tracking task force was figuring out, and it really stemmed from our Boulder fire evacuations and tracking those patients. And once again, the Club Q shooting and being able to track those patients efficiently and know exactly where they're ending up. So really there's a dashboard. So there's multiple ways. One is the EMS agency can see which agencies are responding. As they actually scan the tag and take that patient, the incident commander can actually see the information of, okay, this patient is with this transport agency, ended up at this hospital. But on the backside, there's a platform that's actually available that shows the entire incident, much like Troy was showing with the large scale event that he works with, that basically it's a constant tracking system that you can pull all that information. And the nice thing about it is it can be set up in multiple different ways depending on who's utilizing that information. So one is your local Office of Emergency Management can have a portion of the platform that says, here's who the patient is, here's where they went, but not the medical information. So there's ways to block out to keep it HIPAA high-tech protected. So kind of the need to know side. They don't need to know the injuries. They just need to know where the person is and potentially their condition. Same with dispatch centers. Dispatch centers have platforms that have the ability to be able to track where all those patients went as well and be able to see, okay, Med 16 made it to here now. We know they're there. We'd expect them to be coming back in 25, 30 minutes to the incident, whatever it is. Same thing, even at the state level, there's the capability for the state level, like state's Office of Preparedness and Response, those components that actually could have a very large level dashboard that can track if there's MCIs being declared and what those are within those potential areas, to be able to kind of start to develop a heat map of where can we send state resources that are needed, especially in wildland fire events, evacuation events, things like that. So there's a lot of capabilities, but really what it comes down to is, depending on who is in charge of reunification, and it's typically not one person or one entity, it's a lot of times local law enforcement working with Office of Emergency Management, potentially working with Homeland Security or other statewide or federal resources. There's the ability to very easily get them set up with the dashboard they need, with the information they need, that they can take a photo of a patient and use it to compare to their, facial recognition software. They could take the driver's license once they have that and be able to get those folks reunified. The other key component with reunification that I think is really cool, and the reason we like using it in our areas, is it's not uncommon for EMS to have no clue who that patient is. There's a car crash. We don't know who these people are. It's not our job to figure out who they are. Our job is to care for that patient, get them transported, and try to keep them alive as best we can with the least morbidity and mortality. So if we can rely on scanning that wristband, giving excellent care to that patient, doing a prompt handoff to the hospital with pre-arrival notification, registration, everything talked about, the patient goes to the OR. Later on, they find the patient's ID finally, or sometime during the care of the patient in the hospital, they scan that. Everybody has that information to who that patient is, so we can appropriately document in EPCRs, et cetera. We can figure out who family is. We can start the reunification process. We've even taken it to the step in Colorado that we're engaging our coroner's offices and medical examiners' offices at this point for two reasons. One is so we can track basically the deceased patients and we'll actually tag them over to the medical examiner's office. The coroner ultimately will. So we know that patient is at the coroner's office. In addition, for rural EMS and rural hospitals in particular, we don't have morgues in a lot of our hospitals. So if we have 3, 4, 5 deceased patients, they're taking up hospital beds that we can't care for the continued live patients. So by engaging the coroner's office on there, they actually want to partner with the rural areas to say, okay, XYZ critical access hospital, we can see on the dashboard, because they only see the deceased patients on their dashboard. We can see XYZ hospital has 4 deceased patients. We need to get over there and help offload those deceased patients from them so they can continue to care for the masses that are coming in. So it's really that collaboration. So it's not just for the live patients. It's also helping us offload deceased patients, track them, reunify, unfortunately, in those situations with their family, and be able to provide better care for our continued live patients.
And we've had so many great questions. What we're going to do is we're going to end with one last question here. If we didn't get to your question or is specific and we didn't answer it thoroughly enough, no frets. We have them all logged. We have the contact information to reach out to you guys directly. So we're going to ask one more question, and then we'll wrap up with any final parting thoughts from each of our presenters. And this one goes to Troy, because there is a ton of excitement around what you were talking about, Troy. So we have, and I'm just going to ask them all in a group, and then you can kind of sort through it. Is 1, how does one get involved to Baker to Vegas? 2, do you run into loss of communications during Baker to Vegas? And where are all this stuff happening? What about internet connectivity? Do you signal amplification? You know, this is Death Valley is the name for a reason. So we'll turn that to you.
Yeah, well, thank you very much. And these are all things that we've struggled with. You know, our communications platform has come a long ways. You know, when I started with the race, we were doing through a combination of VHF radios, and we set up our own communication network. And then, believe it or not, we have ham radio operators still to this day at every stage of the race. But the partnership with Pulsera and Verizon has been totally key. So right now we have the ability to have at every single stage, you know, communication. Verizon in those dead spots actually comes out and sets that information up. You know, outside of that, if you had an area that you didn't have the ability to communicate, I mean, it is a little bit of a limitation right now. So if you didn't have a cell signal or something like that, but the moment that you're back into a cell signal, which sometimes can only be minutes down the road, you immediately then are communicating that information back out to your team. You know, one of the things that we didn't mention that I think is another key component of the app is how often do you provide medical care? And for example, let's say we have a runner down at stage 7 of this event. So they're out in the middle of Death Valley. They've collapsed. You know, we had a case where, you know, the team did CPR, they defibrillated, they've now resuscitated that patient. They see the patient fly away on a helicopter. How often do they ever get feedback? They frequently never know what the heck happened. They don't get loop closure. So one of the other unique things now is that if you're there and you have that Pulsera channel, then you have access to that as one of those team members. That patient, now let's say they flew to UMC in Vegas, was met at the emergency department, went from the emergency department to the cath lab. If they have Pulsera on the other end, they can actually provide that information back. They can say, hey, team, fantastic job. Just to follow up on your patient, he went to the cath lab. He had a 99% LAD lesion. We successfully stented him. He's awake, extubated, and joking with his wife. And then that was kind of a similar to a real case that we had out at Baker to Vegas. You know, so you have that full closure on the communication channel. You get that information back. So now your team's more engaged. They really feel like they've had a sense of they know what happened. So it works as an excellent education and engagement tool as well.
Yeah, so let's do just a roundtable, and then Brandon will be closing up. So we'll do in the same order we did before. So Jeremy, any parting course, it's going to be words of wisdom, right? So start with Jeremy, and then we'll go to Eric, finish up with Troy, and then I'll turn over to Brandon.
Yeah, thank you. I really think my closing statement is that, you know, we've been trying to solve this mass casualty thing forever in EMS. This has been going on since emergency medicine started, and well before that, it continues to go on. And what I've really learned throughout my career doing this, both as a paramedic and as a EMS physician, is that we tend to keep doing the same old thing, even though it doesn't work. And that was our situation in Colorado. Was we had a platform that was around for almost a decade plus, and it never got used in any mass casualty event, of which, as we know, Colorado's had a lot of those. So finally, this year is when we said, enough's enough as a group of medical directors. We need to look into this. We engaged our agency partners, the state levels, the RETACs, everything, and really getting that group together to say, enough's enough. What we're doing doesn't work. We actually need to come up with a solution that works every day for patients, has real value to the hospitals and to our providers and agencies. That's how you get buy-in, and ultimately benefits the patients daily as well as in these large scale events. And it's exciting because what I've seen in our time of doing this in Colorado is we have a lot of momentum. And there was a question there that, how do you get people on board with this? How long does it take them to get going? In the beginning, it takes a while. It takes a while for people to get buy-in, but as they see results coming back from cath labs, they see improvement in patient care, it's super easy at that point. Then people want to do it because all of us are in this to do the right thing for patients ultimately. And when we can show that, which we've seen with all of our data substantially, it's an easy sell, right? For our providers, for our leadership, for our state, is that this is good for our citizens. This is good for our visitors. That means it's the right thing to do. And that hasn't existed with other platforms that we've seen in the past and that we've evaluated. Thank you.
All right, over to Eric.
Yep. So there were a couple of questions directly to me that I'll try to answer, and then I'll wrap up. The age, people ask about the adoption. We really saw it as, I'm older, but there was definitely a line of about 45 to 50. And so anybody below that line was like, heck yeah, I want to start using this. And older medics were, they are adopting, but that'll be your group that they go, I just want to call on the phone, or I want to call on the radio. So that was a question that somebody had, and I saw. And then somebody asked about our whole blood. We're doing low titer O positive whole blood. We have about 50 units in the field on supervisor or ambulance vehicles or helicopters. We have a separate blood app that we use for scanning the blood and managing the entire blood process. It doesn't touch Pulsera. It doesn't have it's not associated with wristband. This is my final statement. It's on the bottom of if you ever got an email from me, it's a quote from Margaret Mead that says, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And I really think it's a creed I live daily, it feels like. And certainly I think the Pulsera team is a small group that are pretty committed, speaks to them as well. It's really been great to talk to you guys today.
Wow, thanks, Eric. And then Troy, if you want to wrap us up, and then I'll lead us out.
Right. Thank you. Anytime you have a mass casualty incident or a disaster, it all comes down to communication. Communication is key. And the thing that you don't want in your system is this quilt work of different communication tools. And so I'm really excited to see what they've been doing in Texas and Colorado. We're not there yet in California. We have just a couple of little areas that are starting to pop up and look at this. But what we really need is a statewide solution. Honestly, we need a solution for the entire nation. We all need to be on the same platform. We need to be able to communicate with each other. One of the other projects that I'm working on right now is actually homeless outreach. And I see vast use for Pulsera on the homeless. You are out in the middle of nowhere, down in a river bottom, trying to assess somebody. You need something that's portable, easy to use, and that has GPS capabilities so that I can figure out where I was at, and I can go back and I can find that person a week or 2 weeks later. So getting rid of that quilt work and going to a unified communication system is something that I think everybody needs to do.
Awesome. I agree. And thank you guys so much. Thank you, Dr. DeWall, Dr. Pennington, Eric, for donating your time and speaking to this. Also, a huge shout out to Luke from the STRAC. He's done a lot of behind the scenes work, mostly just keeping Eric in line. So our creative director, Michelle, the content marketing strategist, Nathan, the entire GEMS team. Thank you guys for joining us today. A follow-up reminder email message will be sent to all of the registrants with the link to the archive. It will also be archived at gems.com/webcasts. Certificates in attendance or of attendance will be sent to everyone watching today. It will reflect your time in the session. So thank you again and have a great day.
Thank you.